afternoon, everyone. My name is Sarah Fuchs, and I am a Senior Specialist for the Community Education Department at MDA. We're thrilled to have you join us for today's webinar on FSHD Updates in Research. This learning event is a part of our larger MDA community education programs, which focus on bringing the neuromuscular disease community together around education and resources. Be sure to visit the Community Education section of MDA.org for upcoming events and other webinars. MDA would like to thank Avidity Biosciences and Fulcrum Therapeutics for supporting today's webinar. And for nearly 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through the MDA Care Center Network, and advocating for access and inclusion for the neuromuscular disease community. MDA delivers its mission through research, care, advocacy, and engagement. Since its inception, MDA has invested more than $1.1 billion in neuromuscular disease research. MDA funds projects through the drug development process, from early discovery through translational stages and infrastructure support for clinical trials. MDA care centers are located at over 150 top medical institutions nationwide, providing care from clinicians who specialize in neuromuscular disease. MDA's advocacy network focuses on support for accelerated approvals and novel research, access to healthcare, treatments, independent living, newborn screening, accessible air travel, and more. This focus plays a vital role in shaping laws and policies that support the needs of people living with neuromuscular disease. Our community education and recreations programs are designed to connect individuals and families. We are committed to building a nurturing environment where our members can share experiences, triumphs, and challenges. In 2023, we offered 40 educational programs, over 20 camps, and dozens of other community-based activities, both in person and virtually. If you haven't done so already, we invite you to join the MDA community by registering with us. Registering is free, and please see the link in the chat. You can also learn more about MDA by visiting www.mda.org. Now it is my pleasure to introduce today's speaker, Dr. Robbie Twill. Dr. Twill is a professor of neurology with expertise in neuromuscular disorders, with a special focus on clinical research on FSHD to help understand the causes of FSHD to help develop treatments. Dr. Twill worked closely with two scientists, Dr. Steven Tapscott from Seattle and Sylvier van der Merel from the Netherlands, to confirm that inappropriate expression of the DUX4 protein is the cause of FSHD in 2010. Currently, Dr. Twill, along with Dr. Jeff Statland, are studying the natural history of FSHD to help design current and future FSHD trials. Thank you for being here today, Dr. Twill, and I will turn the time over to you.
So along with myotonic dystrophy, FSHD is the most common adult onset muscular dystrophy with a prevalence of 1 in 8,000 to 1 in 20,000. It is dominantly inherited in most instances or sporadic. Life expectancy is similar to that of the general population. FSHD also affects individuals across racial and ethnic groups. It's been described in individuals in Eastern, Western, and Southern Asia, North Africa, Europe, and in the Americas. There is, however, interestingly, some difference not in the disease itself among certain ethnic groups, but severity of disease can be different. For example, between the Japanese and the European American population, they seem to be less severely affected than patients in our environment. So genetics and the physical features, there are two clinically identical forms of FSHD, FSHD1, which accounts for 95% of all patients with FSHD, and it's autosomal dominant. So one parent can pass it on to the next generation. FSHD2 accounts for about 5%. It's called digenic inheritance because it actually affects two different um, uh, uh, genetic areas on two different genes, on two different chromosomes to cause FSHD2. But clinically, FSHD1 and 2 are exactly the same as far as clinical manifestations. And the distinctive FSHD has a distinctive pattern of weakness, including the face, shoulders, shoulder muscles, upper arm muscles, typically sparing the deltoid, abdominal and paraspinal muscles, and leg muscles, and lower leg muscles and upper leg muscles as well. Distinctive in FSHD is the frequent asymmetry of muscle involvement, and we'll get to the cause of that, some of the things that we're learning recently. The non-skeleton involvement, and that's typical only for the early childhood onset FSHD. And this can include, in addition to muscle weakness, hearing loss, retinal vascular disease, which is also called Coats disease, which is especially the Coats disease is particularly severe, can be particularly severe, and they can lose their vision in the affected eye. But now there are some treatments for that as well. Cognitive impairments, and that is seen rarely and almost exclusively in early childhood onset FSHD. They're more likely to have a reduced capacity in their lungs, um, but this is for pediatric FSHD, but this happens in adults in about 15 to 20% of the patients. There's also a wide spectrum of severity from minimally symptomatic to wheelchair-bound individuals. So this is one of the things that people have kind of published in books for many years that I kind of do not believe in anymore. And so there's always the expression that it starts up in the face, in the shoulders, and the upper arms, and it progresses downwards. But I'm sure many of you sitting in the audience will know that in many instances it can start up here, and then instead of progressing up here, start down in the legs. So there's not a particular pattern that's similar to everyone else. I have one patient, for example, who all of their back muscles are weak. Their back muscles up here, but they have very strong legs and very strong arms. So there's a lot, and we can get back to that. I'll get back to that and tell you my explanation of why we see that. So this is some typical clinical features of FSHD. This is a woman who's closing her eyes. You can see that she cannot close her eyes very tightly. As she's doing that, she's grinning, and you see that one side of the face is not working as well as the other side, and she's not able to whistle because her lips are weak. And down below that is kind of a typical shoulders that are straight, and um, uh, the upper muscles of your thorax are atrophied. And he has an abdominal protrusion, not because he's overweight, because there's a lot of weakness in the abdominal muscles. Again, one of the things that a lot of you know, obviously, is the difficulty with raising the arm is not so much because the arm is weak, but because your scapular muscles, that's the scapula that's sticking upwards, it should, when you activate it, it should come onto your chest wall and facilitate the lifting of your arm. And by pushing onto his scapula, I was able to have him lift up his arm completely. And that's typically what's done in surgery for scapular fixation. Also, this is the same. I'm doing that physically, but can be done permanently for patients who are interested in that. And this is a patient who has severe abdominal muscles as well as back muscles, and that's why he has to hyperextend his back so as not to fall forward. And again, to show you some of the typical asymmetries, this is the same person lying down, and at the top she's lying down flat, not doing anything, and in the bottom, when she lifts her head, her upper abdominal muscles are stronger than the lower abdominal muscles, and the belly button goes up. Again, another example of that is that two young women, they're twins, and you can see that they are kind of asymmetric to each other. They're kind of mirror images of each other. But again, both of them have one arm that's very weak, and the other is not. And again, even with scapular involvement, you can see one side is normal, the other side's not. So FSHD has an unusual genetic cause. Most genetic diseases are the result of a mutation of a single particular gene. And the defect that results in that gene is what causes the disease. In FSHD, the DUX4 gene is present in a string of multiple DUX4 genes that are tightly bound and that they are turned off. And they're usually between 11 and 150 copies of the DUX4 gene. And it's the contraction of if something happens to the chromosome and you lose a significant number of the DUX4 genes, if you go below between 1 and 10, then you develop FSHD1. Because the whole sequence of DUX4 unfolds basically and allows the most distal DUX4 gene to actually express itself and cause damage to the muscles. DUX4 is known to be present in early development and has some important functions that we don't understand very well. But it turns off as people grow, and it's turned off in most of the body. In unaffected individuals with normal DUX4 genes, DUX4 is expressed in early development, as I said, and the only place it's still expressed in somebody who's an adult, a male, it's in the testes and the thymus. The thymus is that gland that's just below your chest, and it's usually reduced and it's not functional when somebody becomes an adult, and so it has no dysfunction on these tissues. This is kind of a visual of what I was describing. So this is the chromosome 4, and DUX4 is at the tip of chromosome 4, one tip of it, one side, and the DNA that spirals over these ring-like these little balls that are inside the chromosome. This is what ties all of the DUX4 genes together. But when you lose a lot of the genes in type 1, you unfold it, and the last gene is the one that causes damage to the muscle. This is in type 1. In type 2, what happens is that there are 3 different genes. The most common one is SMCHD1, is on a different chromosome, is on chromosome 8. And when there's a mutation on chromosome 8, and there's a slight reduction in the number of repeats to 11 to 20, you get FSHD type 2. Clinically, FSHD 1 and 2 are exactly the same. So when DUX4 is expressed, you go to RNA and then to a protein, and and it's toxic to muscle. And this is kind of a visual of this slinky is kind of a visual what happens, particularly in type 1, that kind of, but also in type 2, but for different causes, the opening of this stretch and the production of the DUX4 in the last gene. So disease severity in FSHD correlates with the number of residual repeats. Data from the Rochester-based National Registry, when asking about age of wheelchair use, individuals with 1 to 3 repeats are more likely to be wheelchair dependent in their 20s. Individuals who have 4 to 7 repeats tend to have, in their 50s, they are more likely to get wheelchair dependent. And those who have 8 to 10 repeats are the patients who kind of start getting symptoms of FSHD in their 40s or 50s. And so they're the least likely to become wheelchair bound. But you can see even on this graph that even patients with 1 to 3 repeats, even though the majority of them have severe disease, you can see that there are a lot of exceptions. And again, coming back to what I discussed before, that most of the patients who have 1 to 3 repeats are usually early onset kids with FSHD, and they're the ones who get those more kind of significant medical problems in addition to the muscular weakness. So management of FSHD symptoms. In early onset FSHD, it is important to have affected kids tested early on to try to, if you don't do a hearing loss early in those kids, they may have difficulty learning how to speak. And so when somebody's diagnosed with early onset FSHD, this is one of the things we suggest, as well as an eye exam to make sure that there's no retinal vascular disease that's starting, because it's important before they lose vision, but also because there's treatment for that then can prevent that from getting worse. And also because they are young and because they progress fairly rapidly, they need to have kind of periodic lung capacity measurements. Those are, as probably a lot of you know, it's you exhale into an instrument, and it gives you the how big your lung capacity is. The management for adults is slightly different. Again, periodic lung capacity measurement is important, especially in individuals are more severely affected, especially those who are wheelchair dependent. The reason for that is because as the disease progresses, not everybody, but some people will get a reduction in the lung capacity that can be managed in most instances with nighttime CPAP setup to help you breathe when you're sleeping and you're lying flat on your back. To minimize musculoskeletal pain, a physical therapist who is experienced in FSHD can be very, very helpful. And this is where, I think this is a question that has I've heard multiple times from patients is, where do we go for the best help? You really have to go to bigger medical centers that have a sizable neuromuscular unit, that are familiar with the limitations that patients with FSHD have, and they will have physical therapists who are very experienced and know exactly how to manage your deficits and help you with chronic pain as well. So again, the experienced physical therapists are a really important aspect of of management of patients with FSHD. I would say more important than what we do after we make a diagnosis. So there are other things that come out, and that a lot of people have questions about that. Scapular fixation can significantly improve the ability to raise the arm above the shoulder. However, it does limit the forward and backward movement of the shoulder and can restrict lung capacity. And so surgical intervention should be done by a surgeon with experience, who has a lot of experience doing this. And there are, a number of surgeons who can do that across the country and who do it well. But you have to consider that there might be some side effects from that. Again, it depends on why somebody's asking for surgical intervention. Sometimes it's for, they don't look good with that, and certainly the improving surgical posture is going to look better, but sometimes it comes with a price for that. Again, good surgeons will talk to you about all of that before saying that we should go on with surgery. Limitation of eye closure can be also something that causes irritation of the eyes and can cause swelling, and may require the intervention of an ophthalmologist. There are always also certain drops that can help with that. Again, it's not something that's common, but it can happen to kind of a significant number of patients with FSHD. So, so back in 2010, after about 20 years of research and kind of back and forth between different researchers about what the cause of FSHD is, this was published in 2010. There still was some hesitance among a lot of physicians and researchers. They did not believe that this was the actual cause of FSHD, but I think since then I think this is widely accepted now that the cause of FSHD is the unfurling of the DUX4 and the expression of DUX4 in muscle, which is toxic to muscle. So in 2010, and one of my fellows here was Dr. Statland from KUMC. And when he was a fellow here, and I said, this is shortly after this happened, I said, we have to prepare for clinical trials. And so we started that in 2010. Unfortunately, you cannot get very big funding for that because the NIH didn't fund clinical trials that are not active, basically, but trials that are to prepare for future clinical trials, basically. And the importance of that is that we need to understand how quickly the disease progresses over time. And these trials usually take several years, 2 or 3 years at least. And this gives us a very good idea about how fast, on average, this goes, and is it dependent on the number of repeats that somebody has. And this is crucial information for anybody who wants to do a clinical trial, because they can plan for how long the treatment should be before they stop. And the other benefit from the research study to look at the natural history of somebody with FSHD without treatment is to understand what happens also with changes in your system. For example, we'll take blood samples on a regular basis, not on a weekly basis, but maybe every 3 months, and to see what are some what we call markers in in the blood that can predict um, uh, who is going to progress more rapidly than somebody else. And all of these are important to measure benefit or no benefit from any type of medical intervention. The other thing that has developed since 2010 is the importance of MRI uh, in in uh, in FSHD. And again, this I have to go back to what I mentioned before. What we know about FSHD is that some patients it will progress fairly kind of constantly, whereas a lot of people progress a little bit and nothing happens for a number of years and something else happens. And we know now that in in FSHD, one of the primary problem is the fact that the muscles that are affected that are getting weak are inflamed. And so this inflammation can be followed. You can do a muscle biopsy before and after, but the other way of doing that is doing that just on repeated MRIs. And so this is one of the things that some of the companies that are planning clinical trials are going to be doing in the upcoming clinical trials. So in 2015, we were able to get funding from the NIH. And so we started with 6 sites in the US, and there was a big interest among a lot of other centers to join us. And we ended up having 26 sites, both in the US and many of them in Europe, but also now we're negotiating with not companies, but institutions um, uh, in Asia, in Japan, as well as in China, as well as Hong Kong, as well as in South America. This is really important because their participation in what we call natural history studies makes them familiar with patients, and so they'll be attractive for um, uh, anybody who wants to do a clinical trial, including the pharmaceutical companies. They will know where to go to get the best in, the best sites who are familiar with this disease and how to follow it and manage it. And since the last 7 years now, there's been 2 trials on more than 2 trials actually there, but the trials that are really targeting the core cause of the disease. Um, we'll get to that at the beginning after this slide. So let me backtrack a little bit. So how can we target FSHD and have it improve or even slow down and stop progression in FSHD? So one of the relatively easy thing about DUX4 is that you're blocking something, whereas in somebody who has most of the other diseases are caused by mutation in a gene. So you have to make that gene healthy, and that's much more complicated than what has to be done in FSHD. But you can target it at different points where it becomes an RNA. You can block it here. Or if you're past that, you can attack and block the mRNA. Or even when you have the DUX4 protein is already protected, is in your bloodstream, you can still target it. And so there are potential treatments for all of those approaches that have come up in the last 6 or 7 years. And so these are the clinical trials that are active. Fulcrum is the one that did the REACH study, a phase 3 study of losmapimod, a drug that has been shelved but was shown in vitro, so in a lab, to be able to inhibit DUX4 and block it. And so this Fulcrum study is done, and the results are going to be published very soon. The second entry was in avidity. And again, as you recall from what I said in that previous chart, this is targeting targeting the DUX4 itself. So this is at the bottom of that of what I showed you before. Avidity is using it's doing a phase 1/2 study using binding uh, antibodies binding to transferrin receptor 1, which is present in siRNA and targets the DUX4 mRNA. So it targets it at an earlier time of the production of the DUX4. Another company, Arrowhead Pharma, is getting ready to go into clinical trial. And the other company as well is Roche. Now, they're using what's called a novel myostatin inhibitor. Some of you may remember that there's been studies using myostatin in FSHD. These are other than this present myostatin that Roche is planning to use. The other two did not work enough to produce any benefit for patients with FSHD. Hopefully, the Roche drug is going to be helpful, even if it doesn't improve. It doesn't block DUX4. If it can enhance the growth of muscles, then it can be of benefit. So it can be taken potentially along with one of the other drugs that are targeting DUX4. The other companies also are working on similar approaches. This is not a complete list. There's at least 4 or 5 more companies that are working actively at the present time. So this is really what I had to talk about. But I know, and I'm happy, and I know you have many questions, and happy to respond to all of them.
Thank you so much, Dr. Tuel, for that informative presentation. We will move on to a questions and answers session now. So we will open up the questions. We did have quite a few questions submitted during registration, so we are going to do our best to get through them. So Dr. Tuel, we're just going to do our best here, and if you're available, we might be able to go over just a little bit.
Sure.
To try to get through as many of these questions as we can. So first, what age group is in the early onset FSHD?
Yeah, that's a point of contention among the different researchers. It's usually we're talking about people who are in their early childhood, so up to 7. There's not it's not a well-defined, because there's overlap between the categories of patients. So when we're talking about early onset, we're talking about those who are 3 to 7. Yeah.
Okay, thank you. Can you clarify the use of CPAP versus BiPAP for people with FSHD?
There's not much of a difference. Actually, I think I put CPAP because it's more common, but more commonly known. But BiPAP, for somebody who has reduced lung capacity, a BiPAP is more. BiPAP, yes, is more effective than a CPAP. CPAP is mostly for people who have some lung problems related to, for example, chronic smoking, and have lung disease because of that. So there's a little bit of a difference.
Understood. Thank you. Will the children affected be able to participate in clinical trials?
Yes, I mean, and there was recently after the Fulcrum study was done, there was a lot of the parents of kids with FSHD were asking that question, and the companies um, are taking note of that. And I know the Fulcrum is interested in potentially doing a second study with early onset patients. The other thing that we're doing now is we got another um, grant from the NIH to do a natural history study on kids with FSHD. Um, and it's difficult because it it's a rare occurrence. The pediatric FSHD, they're not frequent. Um, but because of that, we had to kind of um, expand the number of sites that we have who are able to who have kids with FSHD that we can study, because again, the data on the kids um, uh, is going to be very important in how you manage and design the clinical trial in kids.
Absolutely. Another question about clinical trials. How do you know which trial can benefit your individual case?
I don't think you can. I mean, all of the trials, I mean, they go in and they have evidence that this works in animals, but how it's gonna act in humans is always an unknown. I mean, they do, they make sure it's not a toxic product before they get it into. So they test that in animal models or in vitro models, and then when they're certain that there's no potential significant side effect, that they can go forward. But they cannot predict exactly what the benefit is going to be until the study is done. So it can be, I mean, there are many potential good results. Some are better than others. I mean, you can say it stopped progression, it slowed progression. Okay, not as good as improved uh, um, improved strength, and you know, uh, or improved strength to the point that you're completely normal in strength. So these are all of them are to different extent benefits. I mean, I think and again, it's a personal deal. I understand that somebody who's more severely affected would like something that's much more effective, whereas somebody who's not very affected um, um, will settle for something less than that. So that's kind of a very personal decision. But but again, we can't know how that drug is going to work in humans until it's done.
Absolutely. We did link the MDA clinical trial finder tool in our chat box. So if you wanted to use that, that might help you start if you're looking for clinical trials. So that's a helpful resource as well if you're looking into that. Dr. Toole, for FSHD, retinal vasculopathy,
Yeah.
in your opinion, what is the possible mechanism and what kind of cells are affected?
Um, the eyes are not easy to go in and look at and do a biopsy on. So it's really just on the appearance of it. So it's the blood vessels in the eyes that leak basically and cause the uh, damage to the retina and loss of vision. But again, there are treatments that are given to patients who do that now. And so it's very important for it to be diagnosed early and get them get the individuals seen by uh, uh, an eye doctor who can treat that.
Great. Someone else has a question about statin use after FSHD diagnosis. The doctor wants me to use statin, but I'm concerned about muscle damage.
Yeah, that's a point of debate among everybody. Uh, Not everybody who takes a statin will get a problem, but you cannot predict who will get it. And it is something that is more recognized now than it was before. Um, Again, it depends on, that there are non-statin drugs for somebody who has problems with their cholesterol. So it doesn't have to be a statin, but those drugs are usually very expensive, and usually uh, the uh, the companies who are providing the, the, the companies, not drug companies, the commercial companies who are having to pay for it usually will balk on it, and they'll say, no, you can't do that until you first try the statin. But I think you can make, if somebody has any type of muscle problem, I'd say, I mean, uh, a physician can potentially, um, advocate for the patient to get that drug, even if the company that they're working with is not paying for it on a regular basis.
It looks like we also have another question about statins. I stopped taking statins due to muscle loss and changed to red yeast rice. Could this be having the same effect of statins?
Yeah, there are rare reports of that. Uh, yeah, the red yeast rice. Yeah. So this has been reported. It's very uncommon, but it does happen once in a while.
Great. It looks like, so we're going to do a couple more questions and then we're going to wrap it up. Um, so once a medication has been approved to block DUX4, is there a way slash medication to regenerate very weak muscles?
It depends. That's a reality. I mean, there are muscles that get to the point where, if you look at them under microscope, there's only connective tissue and fat that's left. It would be very, very hard to regenerate that. There may be ways of doing that in the future, potentially, but not at this point. But I think anything that any muscle that's still relatively functional, can get stronger. But if you get to the point where the muscle is completely atrophied, that's going to be a tough thing to do.
Okay, do you know anything about neuroacupuncture or hydrotherapy, and are they helpful?
Not much, but if they're helpful, they may be helpful mostly with um, patients who have pain, that can help with pain. But it will not have an effect on the muscle itself.
Okay, we'll do two more questions.
That's fine. You can
Um, thank you so much for
three
hanging on
three or
here
five
for us.
questions. That's fine.
So what about tamoxifen? I noticed more severe progression and weakness after taking tamoxifen.
Um, I Yeah, tamoxifen is something that mostly um, uh, taken in patients who have cancers, and so it's not something that I'm very familiar with as far as whether it can be toxic to muscles. Um, so I don't have an answer to that, but it may be another factor other uh, than the medication itself.
Okay, thank you. What are the non-statin drugs available and where do I find out more information?
Um, I mean, most primary physicians will know that. There are not many. There's one or two. Um, there are some uh, um, there are some medications that are supposed to help, not medications, even um, something that you can get over the counter that can help with, um, uh, but they're just not significant enough in helping reduce the cholesterol in somebody who has it. And so really there's not much, if somebody's really affected, or if somebody, I mean, uh, uh, getting, reducing weight, exercising, that can significantly reduce your cholesterol level. Again, I know that's going to be difficult for somebody who has FSHD to do that. So it really comes down to the um, the statins and the non-statin drugs that have come out recently.
Thank you. And then I know a recurring question that came up was about the treatment landscape and
Yeah.
what are we expecting for the future? So a lot of people are asking, when we're going to see effective drugs and new drugs and treatments available. So do you have any insight into that you'd like to share?
So I mean, even though I and most of us doctors want to be very optimistic, and we are optimistic that it's going to work, uh, but clinical trials take time. The good thing about what's going on in FSHD is that there are a lot of companies basically entering the field at the same time. I think, um, and some of them have medications that have worked in other muscular diseases. It doesn't mean that it's going to work in FSHD, but that's a good sign.
Understood. Well, thank you so much for all of your expertise and for taking time to answer our questions and answer session. Um, And if everyone or all of our participants do not mind just hanging on for just a second, we're going to wrap it up here. I just have a little bit more information for you. But Dr. Tuel, thank you so much for your time today.
Oh, you're welcome. Thank you. Bye.
If you are new to MDA and have been diagnosed with a neuromuscular disease under MDA's umbrella, or if you are a loved one of someone who is diagnosed, we encourage you to stay engaged with us at MDA. You can do this by visiting mda.org/join and completing a short form. Joining is free and will keep you up to date on the latest research, educational programs, and supports. Before we go, I want to highlight some upcoming MDA community education events that you might be interested in. You can learn more about these events by visiting our website, scanning the QR code on your screen, or clicking the link in the chat box. First, MDA will be hosting 4 in-person Engage symposiums across the country. Join us for these half-day multi-session programs with both disease-specific learning and general learning sessions that are applicable to all neuromuscular diseases. These events are free to the MDA community. Next, I want to highlight an upcoming webinar we are hosting on nutrition with neuromuscular disease. Our speakers will highlight nutrition, healthy choices, information for children and adults, feeding tube basics, and acquiring services. As always with our webinars, if you register online and are not able to join the day of the event, we will be sure to email you the recording and any companion materials after the conclusion of the presentation. We'd again like to thank Avidity Biosciences and Fulcrum Therapeutics for supporting today's webinar. And we would love to hear your comments about today's webinar. Once you leave the webinar, a webpage will automatically pop up with a short survey about today's webinar. Completing this survey will provide us with important insights as we plan for future educational programs. If anyone has any questions after this webinar, please feel free to contact MDA's Resource Center at 1-833-ASK-MDA1 or email resourcecenter mdausa.org, and we will be sure to get back to you. Thank you again to Dr. Tuwell for your time, and this concludes today's webinar. We hope to see everyone again soon.